Welcome to Concept in Medicine. In today's session, we are going to be looking at hypertensive crisis. Hypertensive crisis. Let's begin by looking at what hypertensive crisis is. When we say hypertensive crisis, it's referred to sudden rise in the blood pressure. That is, the systolic blood pressure of greater than or equal to 180 millimeters of mercury and or diastolic blood pressure greater than or equal to 120 millimeters of mercury associated with or without progressive target organ dysfunction. For the hypertensive crisis, there are two types. The first one is going to be hypertensive urgency. When we say hypertensive urgency, simply put, it is a hypertensive crisis without progressive target organ dysfunction. And for hypertensive urgencies, they can present asymptomatically or present with non-specific symptoms. And what are the non-specific symptoms here? We are talking about headache, which will be found in about 22% of patients. We can talk about epistaxis, which will be found in about 17% of the patient. Psychomotor agitation, which will be found in 10% of the patient. And lastly, faintness or dizziness. These are non-specific symptoms, meaning that they can also be found in other conditions, not necessarily in hypertensive urgency. The second type of hypertensive crisis is going to be the hypertensive emergency. The word emergency means that it is more serious than the hypertensive urgency. And when we say hypertensive emergency, simply put, it is a hypertensive crisis complicated by evidence of impending or progressive target organ dysfunction. A hypertensive crisis complicated by what? Evidence of impending or progressive target organ dysfunction. We call that hypertensive emergency. For the hypertensive emergency, it will typically involve three systems. Which system are we talking about here? We are talking about one, the cardiovascular system, two, the renal system, and three, the central nervous system. Those are the three systems that will be mostly affected by hypertensive emergency. Or in hypertensive emergency, those systems would be experiencing the progressive target organ dysfunction. The next one is, how do patients with hypertensive emergency present? Typically, they are going to present with chest pain, which is going to be more common in about 27% of patients. Some will come with dyspnea, that's shortness of breath, in about 22% of the patients. And finally, neurological deficit, which will be found in about 21% of the patients. And for the neurological deficit, it could come in the form of an altered mental status, or it could also come in the form of a focal neurological deficit. All right, let's move ahead and look at the clinical syndromes associated with hypertensive emergency. The clinical syndromes associated with hypertensive emergency. So we'll take them according to the systems. So the first one is going to be central nervous system. What can we have there? The first one, hypertensive encephalopathy. For the hypertensive encephalopathy, it has to do with the high levels of the blood pressure. And we know that blood pressure is equal to the cardiac output multiplying the peripheral vascular resistance. So in the case of hypertensive encephalopathy, with an increasing vascular resistance, what is going to happen is that there is going to be a loss of the central nervous system autoregulatory function. And when that happens, the blood vessels are going to dilate, and then there's going to be leakage of the liquid aspect of the blood into the interstitium as well as the cell, and that will lead to cerebral edema. And that is where the genesis of hypertensive encephalopathy is going to come from. The next one is going to be the cerebrovascular accident. For the cerebrovascular accident, with rising blood pressures in the intracranial space, there could be constriction, vasoconstriction, intensive vasoconstriction, which will restrict the amount of blood flowing to the brain matter, and that could lead to an infarction, ischemia, then infarction, and that could give rise to the ischemic or infarctive stroke. Or in the other way around, the high pressures in the blood vessels of the brain, that is going to be the Willi circle, can cause the blood vessels to rupture, and that could give credence to the hemorrhagic stroke. The next one is going to be subarachnoid hemorrhage. For subarachnoid hemorrhage, the patient is going to present with the worst headache of his or her entire life, and that headache is described as a thunderclap headache. And the most common cause of subarachnoid hemorrhage is the ruptured Berry's aneurysm. Ruptured Berry's aneurysm. The next one under the central nervous system is going to be hypertensive retinopathies. Hypertensive retinopathy. The next one, intraparenchymal hemorrhage, and finally cerebral infarction, and that could come from a sufficient decrease in blood flow to the brain matter, and that will lead to cerebral infarction. Let's move ahead and look at the next system. That is going to be the cardiovascular system. For cardiovascular system, one, we are talking about congestive cardiac failure. You should know that hypertension is the most common cause of left ventricular failure, and the most common cause of right ventricular failure will be left ventricular failure. So indirectly and directly, hypertension accounts for what? Congestive cardiac failure. That is the coexistence of both left and right ventricular failures. The next one is going to be aortic dissection. The next one, aortic aneurysm. The next one, acute coronary syndrome, which is a constellation of three conditions. And what conditions are those? We are talking about the XT segment elevation myocardial infarction, the non-XT segment elevation myocardial infarction, and unstable angina. And it will come about as a result of an imbalance between myocardial oxygen demand and supply. All right, let's move to the next system, which is going to be the pulmonary or the respiratory system. And there we'll have acute pulmonary edema. Acute pulmonary edema. And these will be responsible for cardiac arrhythmias in patients with heart failures, especially the left ventricular failures. The next system is going to be hematological. In the hematological system, there is what we call acute microangiopathic hemolytic anemia. Then we move next to the renal. For the renal system, the syndrome that is associated with hypertensive emergency is what we term as what? Hypertensive nephrosclerosis. And hypertensive nephrosclerosis is coming as a result of what? Ischemia. And when it happens, it can give rise to what? The renal failure in the form of acute kidney injury. The next system is going to be the skin. For the skin, there is what we call material hypertensive ischemic leg ulcers. Material hypertensive ischemic leg ulcers. And for that, it's going to be on the skin. And its pathological hallmark is referred to as ischemic subcutaneous arteriosclerosis. That is the pathological hallmark of the material hypertensive ischemic leg ulcers. Then finally, we have the obstetric disorders, and that is going to be in the form of preeclampsia and eclampsia. Preeclampsia simply is hypertension plus proteinuria with or without pathological edema. Then eclampsia will be the hypertension plus proteinuria plus seizures. Okay, let's move ahead and look at the etiology of hypertensive crisis. So the first etiology we are talking about is hyperthyroidism. That has to do with an increase in the thyroid hormones. Yes, and that could give rise to what? A sudden increase in the blood pressure. And we know the threshold. The threshold for hypertensive crisis, we know that the systolic blood pressure should be greater than or equal to 180 millimeters of mercury, and or the diastolic blood pressure greater than or equal to 120 millimeters of mercury. The next one is going to be the renal disorders. So hypertensive emergency association can be a renal disorder, and again, a renal disorder can give rise to what? Hypertensive emergency, as well as what? Hypertensive urgency, because it has to do with what? The renin. The renin-angiotensin-aldosterone system has an origin from the kidneys. All right, the next one, we are looking at systemic lupus erythematosus. That's a collagen vascular disorder. It can also give rise to what? The hypertensive crisis. The next one, preeclampsia and eclampsia, which are constituting the obstetric causes. The next one, spinal cord injuries, head trauma, yes, can also give rise to hypertensive crisis. Next one, physiological stress in the post-operative period following the following operations. Which ones? Cardiothoracic operation, neurological and vascular surgeries. Yes, can also give rise to hypertensive crisis. The next group is going to be drug-associated. For the drug-associated causes, we can look at the illicit drugs like cocaine, methamphetamines, tricyclic antidepressants, NSAIDs, that's non-steroidal anti-inflammatory drugs, monoamine oxidase inhibitors, phencyclidine also. Then under the drug associated, so we can also look at the drug combination. Certain drug combination with monoamine oxidase inhibitors can increase the concentration of the monoamine oxidase inhibitors, and that could result in hypertensive crisis. What are these combinations? The first combination is going to be a monoamine oxidase inhibitor plus selective serotonin reuptake inhibitors. Then the second one is going to be monoamine oxidase inhibitors and diets rich in tyramine. And what are these diets rich in tyramine? We can think of old cheese, wine, and chocolate. These diets are rich in what? Tyramine. And anytime a patient who is on monoamine oxidase inhibitor therapy and taking diet rich in tyramine, it increases the concentration of the monoamine oxidase inhibitors, and that could result in hypertensive crisis. All right, let's move ahead and look at the clinical presentation. The clinical presentation, we made reference to that at the beginning, but we'll make reference to them again. For the clinical presentation, these are going to be the typical presentation, and it's going to be based on whether it's a hypertensive urgency or hypertensive emergency. So let's take the first one: chest pain, dyspnea, that's shortness of breath, neurological deficit. These are typical for hypertensive emergency, which we stated at the beginning. Then when we go to the other side, which is going to be severe headache, epistaxis, psychomotor agitations, and faintness, they would be affiliated to hypertensive urgencies, and we said that they are non-specific symptoms. All right, let's move on and look at the investigations that can be done in hypertensive crisis. For the investigations, we can do an electrocardiogram to rule out left ventricular hypertrophy, myocardial infarction, myocardial ischemia, arrhythmias, and so forth and so on. The next investigation can do urinalysis to rule out an acute kidney injury, and we are going to be looking out for proteinuria and hematuria. The next one is going to be a urine pregnancy test in females of reproductive age, and that will help us to rule out preeclampsia and eclampsia. The next one is going to be blood urea electrolyte and creatinine. It can also be used to assess the kidney function. Then the next one, urine or semen toxicology screen in the case of the illicit drug abuse like the cocaine, the methamphetamines, the amphetamines, and so forth and so on. Yes, it could help in that regard. The next one is going to be a full blood count and peripheral blood smear, and this could help us isolate schistocyte, which is confirmatory for acute microangiopathic hemolytic anemia. The next one is going to be cardiac troponins T and I, which are the cardiac biomarkers anytime we are thinking of myocardial infarction. It will help us to rule out acute coronary syndrome. The next investigation is going to be chest x-ray. Chest x-ray will help us to rule out an acute pulmonary edema, mediastinal widening, and cardiomegaly, which will occur in congestive cardiac failure or left ventricular failure. And finally, the brain CT scan, which will be useful for us to rule out intracranial hemorrhages as well as the hemorrhagic stroke, etc. All right, the next thing we'll be looking at is going to be the treatment. All right, let's move ahead and look at the treatment of hypertensive crisis. And for the treatment, we are going to go in two forms. That is going to be for hypertensive urgency and hypertensive emergency. Let's start by looking at the hypertensive urgency. What are the protocol? What are the requirements with relation to the treatment? You should know that for hypertensive urgencies, they often do not require urgent treatment with parenteral antihypertensives, meaning that once you are not going to give intravenously, then definitely it's going to be oral. Because most of the hypertensive urgency patients present with no symptoms, most of the time it's advisable to keep them in a quiet room for about 30 minutes, retake the blood pressure, and it's only after it is still elevated or high, that is when you think about what? Giving the oral antihypertensives. And for the oral antihypertensives, it's either you are initiating them, modifying them, or reinstituting them. Initiating them means that it's a newly hypertensive, has not been on the medication. Modifying the dose means that they are on the antihypertensives orally, but the dosage is not adequate to take care of the blood pressures. Then reinstituting, meaning that they have been non-compliant. It means they've started and they stop. So you reinitiate, you restart the medication for this particular patient. And the goal of treatment for both hypertensive urgency and emergency is to reduce the blood pressure. That is the primary goal. You should also know that rapidly reducing the blood pressures below the autoregulatory range of an organ system. Which organ system? The cerebral, the renal, and the coronary vascular beds can result in hypoperfusion and further lead to ischemia and infarction. So if it's taking place in the heart, you have myocardial ischemia, and further it will lead to what? Myocardial infarction. If it is the brain, then you have cerebral ischemia, then it will lead to what? Cerebral infarction. Renal to renal ischemia and lead to renal infarction, in that order. So it's not advisable to reduce the blood pressure drastically below the autoregulatory range for a particular organ system. For hypertensive urgencies, there are no designated target BPs that you look at. It's a matter of reducing the blood pressures, but not going below the autoregulatory range for a particular organ system, as you've stated. Then, most of the patients with hypertensive urgencies are treated as outpatients. They are treated as outpatients, but some are admitted based on their presentation and also as a way to ensure that there's close follow-up and compliance, especially patients who are not compliant, they are non-adherent to the drug medication or to the drug regimen. They are non-adherent. Such patients will be admitted and be followed up closely and ensuring that they take their drug regularly. You should know that for hypertensive urgency, follow-up, monitoring, and counseling are the ultimate ways of achieving the objective of treatment for hypertensive urgency. For hypertensive urgency, to know that gradually reducing the blood pressure over a period span of 24 to 48 hours is the standard. Is the standard of treatment. Is the accepted approach of treatment. Now let's move ahead and look at some of the oral antihypertensive agents or oral hypotensive agents that are used in hypertensive agency. So the first one is going to be captopril. Captopril belongs to the angiotensin converting enzyme responsible for conversion of angiotensin 1 to angiotensin 2. So when you block it, angiotensin 2 is no longer produced, and that will help reduce the blood pressure. The next one is going to be labetalol. Labetalol is a non-selective beta blocker with an alpha antagonism, with an alpha 1 antagonism. It's a non-selective beta blocker with an alpha 1 antagonism. Then the next one is going to be prazosin, also an alpha blocker, then clonidine. So these are the medications that are used in the treatment of hypertensive agency, and they are given orally, and they are antihypertensive medications. Now let's move ahead and look at the treatment of hypertensive emergencies. For hypertensive emergency, JNC7, that's the 7th edition of the Joint National Committee on the Treatment and Prevention of Hypertension, recommended that when a patient with hypertensive emergency is seen at the emergency department, they should be treated as inpatients in an intensive care unit, reducing the mean arterial pressure by at most 25%. It should not go beyond 25%. By at most 25% in the first hour. As an initial goal. Then, if patient is stable, a goal of a systolic blood pressure of 160 millimeters of mercury and diastolic blood pressure of 100 to 110 millimeters of mercury within the next 2 to 6 hours. Those are the recommendations by the 7th edition of the Joint National Committee on the treatment of hypertensive emergency. This would work. The recommendation would work for a lot of the associated syndromes, but there are some exceptions. And what are these exceptions? The first exception is going to be in aortic dissection, where the blood pressure, that is the systolic blood pressure, should be reduced to about 120 millimeters of mercury within 20 minutes. And that is an exception from the JNC7 recommendation. Another exception has to do with the ischemic stroke and the intracranial hemorrhages, where the blood pressure would have to be reduced and it does not need to follow what the JNC recommended. There are special guidelines for their treatment as well, according to the guidelines of the American Stroke Association and American Heart Association. Their guidelines can be used to specially attend to ischemic strokes and intracranial hemorrhages. Now, for hypertensive emergency, distinguishing it from hypertensive urgency with regards to treatment, for hypertensive emergency, intravenous antihypertensives are required. But for the hypertensive urgency, oral antihypertensives are required mostly. So what are some of the examples of these intravenous antihypertensives that are used in hypertensive emergency? So let's have a look at that. The first one is going to be the calcium channel blockers. And what are these calcium channel blockers? We are looking at nicardipine and clevidipine. The next one is going to be nitric oxide dependent vasodilators. The first one is going to be sodium nitroprusside. Sodium nitroprusside, which is the drug of choice for hypertensive encephalopathy. Then we can also talk about nitroglycerin, used mostly in angina and even in unstable angina, simply in acute coronary syndrome. The next one is going to be the direct arterial vasodilators. Example is hydralazine. Hydralazine, when being used in hypertensive emergency, has to be used with care because it can crash the blood pressure, so it has to be used with care. The next group is going to be the antiadrenergic drugs. And what are these drugs? We are talking about Exmolol, which is a selective beta-1 antagonist, a selective beta-1 blocker. The next one is going to be labetalol, which is a non-selective beta blocker with an alpha-1 antagonism. The next one is phentolamine, which is a non-selective alpha antagonist. The last group is the ACE inhibitor, which example is the enalaprilat. And what is enalaprilat? Enalaprilat is an intravenous antihypertensive and is the active form of enalapril, which is an oral antihypertensive. And you should know that enalaprilat is the active form of the oral enalapril. which is an ACE inhibitor, and is the first dicarboxylate angiotensin converting enzyme containing antihypertensive, which is given parenterally. Then somebody will ask, why is it not given orally? You should know that when enalapril is taken orally, it first pass goes through the liver, which is metabolized or hydrolyzed into the dicarboxylate form known as enalaprilat. So when you are taking enalaprilat orally, when it gets to the gut, it is poorly absorbed. Giving it intravenously is best because it has already been hydrolyzed into the form which would have been when enalapril is acted upon by the hepatic esterase. So when given intravenously, it acts directly without having to go to the liver again, because the product that will be gotten from the liver is what is being given intravenously. So when you take enalapril orally, it is hydrolyzed by the hepatic esterases to give you the dicarboxylate or the dicarboxylic acid form of enalapril, which you call enalaprilat. So it's not advisable to take that medication orally. That's enalaprilat. It is given intravenously, parenterally. On that note, we've come to the end of this interesting lesson. I believe you've learned something interesting today. But don't forget to subscribe to my channel, like, share, and recommend to friends. And do not forget to recommend the next concept you would like to see on my channel. And also, make sure to put on a notification button. My name is Dr. Del, and once again, this is Concept in Medicine. Bye-bye.